Pneumonia is an infection in the lung. And pneumonia is frustrating because you do have to learn the organisms that are going to cause pneumonia and which organisms are going to be associated with which clinical scenario, even though most of the time pneumonia is strictly empiric coverage because you do not capture an organism. So what we're going to do is start off by explaining the backbone, that is the spectrum of pneumonia. Then we'll talk about some of the organisms that cause different types of pneumonia and what you need to look for in terms of risk factors. That's mostly for the test. And then go through an algorithm of how you actually treat someone who might have a pneumonia or something more sinister. And then we'll finish off with some of the specifics regarding PCP pneumonia, the flu, and who needs to be admitted. So, because it is an infection of the lung, the backbone of pneumonia is going to be fever. That tells you there's an infection, and cough. That tells you the infection is in the lung. And that cough is most likely going to be productive of sputum. So productive cough and fever gets you to infection in the lung. If you have fever and a cough and a negative chest x-ray, that is no consolidation, consider this bronchitis. If you have fever and a cough with a positive chest x-ray, that is a consolidation, that is classically pneumonia. If you've got fever, cough, and cavitation on the chest x-ray, that's likely to be an abscess. And all the while, don't forget viral illnesses like the flu. And of course, there are other infectious organisms like TB and fungus, but we're not going to consider those in this lecture. What you do need to be able to do, though, for the test is associate organisms with risk factors. For life, what I want you to do is break it down into community-acquired pneumonia and healthcare-associated pneumonia. There are going to be different organisms that the person's at risk for if they're just from the community or they're healthcare associated. And for this discussion, a hospital-acquired pneumonia is equal to a healthcare-associated pneumonia because they have the same organisms. This is more bureaucratic, HAP, HCAP, VAP, rather than microbiologic, but community-acquired versus healthcare-associated is microbiologic, so you do need to separate the two. So how do you do that? An HCAP pneumonia is someone who has been exposed to the building. Within 90 days, the person has had exposure to dialysis center, a hospital, or a nursing home. And not someone who works there, someone who has been admitted, has lived there, or been a patient. If that has happened within the last 90 days and they get a pneumonia, HCAP. So a community-acquired pneumonia would be greater than 90 days from the building. And I say building because it helps remind you that it's more than just hospitals. It's also other healthcare delivery centers, excluding clinic. A hospital-acquired pneumonia is a pneumonia that you don't have when you get admitted. And then more than 48 hours later, you develop the pneumonia. So a HAP, hospital-acquired pneumonia, is a pneumonia you get after being admitted to the hospital for something else. And a ventilator-associated pneumonia, of course, has a ventilator. So community-acquired pneumonia is going to be a pneumonia that occurs greater than 90 days from exposure to a building and less than 48 hours from admission to a hospital. And the organisms here are going to be strep pneumo, Moraxella catarrhalis, and H. flu. Strep pneumo is by far the most common overall. H. flu you're going to look for in people who are COPDers or smokers. But there are still some others you have to know about, like Klebsiella and other gram-negatives. These are going to occur in people who are at risk for aspiration. Those are the alcoholics and those with suppressed mentation. Staph aureus, this is post-viral. So someone had a viral illness, then they came back into the hospital because they have a new pneumonia a week after the viral illness. That's going to be Staph aureus. and Legionella. This is someone who is immunosuppressed, generally the old smoker who also has immunosuppression. And these organisms are lumped together because they're treated the same way. Community-acquired pneumonias are all treated exactly the same way empirically, which is why it's silly to associate risk factor with organism, but the test will ask you to do that, because you're going to treat a community-acquired pneumonia with a third-generation cephalosporin, ceftriaxone, plus a macrolide, like azithro, or the respiratory fluoroquinolone, moxifloxacin. Doesn't matter which one you pick, both sets will work. Once you get into the healthcare-associated pneumonia, however, you're going to be worried about two things, and that is going to be Pseudomonas and MRSA. And as we learned from the antibiotic ladder lecture, you are not going to be able to cover Pseudomonas and MRSA with these antibiotics. So you need to have anti-pseudomonal coverage, Pibtazo, or carbapenem, or cefepime, and something that covers MRSA, vancomycin. Of course, there will be alternates to this, but these are the ones that people use the most often: healthcare-associated pneumonia, vancomycin. But then don't forget about the immunosuppressed, where you can have TB, fungal, or PCP pneumonia, Pneumocystis jirovecii. Either name still flies. And if you're going to be treating PCP, you're going to be using trimethoprim sulfa, Bactrim, with or without steroids. We'll get to that in a minute. Okay, so empiric coverage, you're just going to treat them. Now this whole while, you're probably thinking, hang on a second, community-acquired healthcare-associated pneumonia, what about that typical and atypical pneumonia and certain bugs like mycoplasma and chlamydia versus strep pneumo? For step one, that was true. Now, you cannot determine which type of pneumonia, typical or atypical, it is based on the clinical presentation. Nothing in the history, physical, or chest x-ray tells you the underlying microbiologic organism. Instead, what I'd like you to do is consider this framework. The person who's not that bad, who doesn't have a consolidation on their chest x-ray, but still has a fever and a cough, probably has bronchitis, not an atypical pneumonia. Whereas the person who has the consolidation on their chest x-ray, who has pneumonia, who's very ill, who needs to come into the hospital, is a bit sicker. So rather than see it typical versus atypical, see it as a spectrum from there's a not that bad infection in the lung to a really bad infection in the lung. And the idea being that bronchitis is generally treated with oral antibiotics and they go home, still picking the usual suspects, whereas pneumonia gets IV antibiotics and they come into the hospital. The same will be true with an abscess. So stop thinking about typical versus atypical organisms versus other organisms. Start thinking instead about community-acquired pneumonia and healthcare-associated pneumonia, but you still need to link the risk factor to the organism for the test. Let's tackle this another way. Someone comes in with a fever and a cough. You are going to get a chest x-ray to look for that consolidation and get a pulse ox to see how bad it is. Now you're going to be tempted to get sputum cultures. Don't do that. They're almost never high yield enough. If there's less than 10 epithelial cells and greater than 25 neutrophils, that's a good sample. But most people can't do that. What they usually give you is spit. And your mouth is not sterile, so some bacteria will grow, but it very rarely changes your antibiotic management. You'll also be tempted to get blood cultures. And while you should do that, they very rarely yield anything in the way of changing antibiotics. Blood cultures are only positive in 10% of pneumonias, and it usually does not change the antibiotics you use because the course of antibiotic therapy is generally around 5 days anyway. So these are not bad things to do, but in the diagnosis of pneumonia, you need the chest x-ray. The chest x-ray could be negative, in which case we're considering this bronchitis. The chest x-ray could have cavitation, which will also present with foul-smelling sputum. This is a cavitary lesion. Now, not all cavitary lesions are abscesses, so what you're going to need to do is get a CT scan. The CT scan is going to show you whether this cavitary lesion is fungus, TB, or truly that abscess. And the abscess of the lung is one of those abscesses that does not need to be drained. So abscess of the lung, you just need to treat with antibiotics. You still want to pick that third generation cephalosporin, but now you want to change it up and cover gram-negative and anaerobic organisms. You do that with clindamycin. But where we're talking about in this lecture is pneumonia, so you're probably going to have consolidation. And consolidation on the chest x-ray means that this is a pneumonia. But as we just talked about, pneumonia is not enough. What you have to do next is assess exposure to the building and time. Greater than 90 days from healthcare exposure, less than 48 hours from hospital admission. If that's true, that is, they have exposure or they've been in the hospital, they have an HCAP, and they need to be treated with anti-pseudomonal coverage, piptazo, plus MRSA coverage, vancomycin. If they have not had that exposure, they're community-acquired pneumonia, and they can be treated with either a third-generation cephalosporin, ceftriaxone, and a macrolide, azithro, or a respiratory fluoroquinolone, which is moxifloxacin. If all they had was that bronchitis, which to me is the same as ambulatory pneumonia, not that bad, then you can de-escalate from the typical third-generation cephalosporin plus a macrolide. You can give them something less aggressive. So the bronchitis, the not that bad pneumonia, mirrors this treatment where you can give them a macrolide, like azithromycin, or doxycycline, or the respiratory fluoroquinolone, moxifloxacin. Bronchitis, ambulatory, gets oral. Pneumonia, inpatient, gets IV. You have to decide between anti-pseudomonal coverage and MERS coverage versus not that. And an abscess needs to be given anaerobic coverage. There's a wild card in here. If you have pneumonia and you're HIV positive and have a CD4 count less than 200, that is AIDS, if that's the case, you need to give consideration to PCP. The way you're going to suspect PCP is going to be the chest x-ray that's not a solid consolidation. It's going to have patchy diffuse infiltrates. It's going to be more subacute with a slowly developing cough, shortness of breath, and dyspnea. They're going to have AIDS. The way you make the diagnosis of PCP pneumonia is on sputum stain. But you need to do a silver stain, not a sputum culture. If the sputum stain is positive, then you're going to treat with trimethoprim sulfa. And you need to decide, are you also going to give steroids? The way you do that is if they are hypoxemic or they have a low PaO2 on their blood gas, they need steroids. If not, all they need is the Bactrim. The diagnosis is made on a sputum stain, and you suspect PCP because they have pneumonia symptoms, are immunocompromised, the LDH is elevated. All right, so despite this wild card, let's talk about who needs to be admitted. And that is going to be either the CURB 65 or the Pneumonia Severity Index. The ED uses CURB 65. Internal medicine uses Pneumonia Severity Index. The CURB 65 is a very rapid triage. It has 1, 2, 3, 4, 5 components. Any one positive, and it is admit. So the idea is the CURB 65 says, does this person need admission or not? The Pneumonia Severity Index is really complicated, and you'll have to use an online calculator. If the Pneumonia Severity Index is used, it gives you an objective way of saying, can this person go home? Do they need the floor? Or do they need the ICU? It's a little bit more involved. Now, these things exist, but it turns out that clinical acumen is just as good as these scoring systems, where these scoring systems give you an objective way of checking yourself. Do you know if this person is sick or not? And I'd like to close with influenza. Flu kills people. The patient presentation is going to be fever, cough, and myalgias. And it's the myalgias that give away the flu. The diagnosis is going to be made with a flu swab. That's a nasopharyngeal washings or bronchioalveolar lavage. You can just refer to it as a flu swab. And if positive, the treatment is with Tamiflu, the seltamivir. And of course, you can prophylax against the flu by getting your vaccine annually. All right, so pneumonia, not that complicated. What you have to memorize is these associations for organisms to risk factors, and then memorize the different treatment options you have based on the severity. If it's not that bad, oral therapy with azithromycin, doxycycline, or moxifloxacin. If it is bad, it's a pneumonia, you then have to decide, do I need better coverage and a pseudomonal and anti-MRSA? And if not, then you can choose ceftriaxone plus azithromycin or moxifloxacin. And if they're in abscess, you need clindamycin instead. Be careful of PCP and flu, which don't fit this mold, but could be thrown at you on a test question. That's pneumonia.